Hello and good evening, everyone. Welcome to our 30th Blue Earth virtual seminar. Blue Earth virtual seminar is a platform that allows health professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Earth Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Adam Getachew. I'm the co-founder and CTO at Blue Earth Ethiopia. And it's a pleasure to have Dr. Kirubel here with us. And he's going to give us a presentation on the acute respiratory distress syndrome. So Dr. Kirubel Teshome is an assistant professor of emergency medicine and critical care.
Okay. Thank you, Adam, for giving me this chance. And good evening, everyone. Today we'll discuss on AR days. My name is Dr. Kirubel, as Adam told us. And I'll start. So this is my presentation outline. We'll start with introduction. We'll see some definition of AR days in adult and pediatrics also, and epidemiology of AR days, and clinical presentation, the workup, and treatment. So, as you know, ARD is one of the life-threatening conditions we face in commonly in the ICU and emergency setups, and it has been described since the first literature concerning ARDs, which is printed out in 19th century, and it has been given a lot of names. So to say something about the definition of ARDs, so in 1960s, in civilians, doctors, clinicians, they started to say shock lungs, and in 1967, there was an adult. It was named as adult respiratory distress syndrome in 1967, and after that, clinicians used to notice this syndrome in pediatrics population also, in addition to the adults. So the name was supposed to be changed. So in 1994, and American European Consensus Council came up with the term acute respiratory distress syndrome and started to define both in adults and the pediatrics. Okay, so then also they added another term on this one, and they added the issue called acute lung injury. So it was perceived later, it was perceived to be one of the spectrums, milder form of the ARD. So in subsequent definitions, it was cancelled out. Okay, so then comes Berlin definition in 2012 and Kigali modification in 2016. So we'll see the American European Consensus Council and Berlin Kigali side by side. Okay, this slide tries to show the definitions between these two definitions, the difference in these three definitions. The first we see in 1994, the Consensus Council. So they said acute condition with bilateral infiltrates and the severe hypoxia, which is not caused by the cardiogenic pulmonary edema. And in Berlin, they started to tell specific time duration since the insult. So they said less than 1 week after the clinical insult or respiratory symptom, that is a time limit. Okay, or then the radiologic findings, radiologic manifestations are bilateral opacity not fully explained by fusion, consolidations, or atelectasis, especially consolidations related to malignancies and such. Then concerning the origins, it's supposed to be not fully explained by cardiac dysfunction or fluid overload. And the severity, they have to use using 5 centimeter of water CPAP pressure, and they classified it as mild, moderate, and severe. And going to the Kigali modifications, as you know, before we go to the Kigali modification in Berlin definition, they used the mild, moderate, severe, depending on the PF ratio, partial pressure of arterial oxygen over FiO2 ratio. So to see this, we need to have ABG, and especially living in Africa, where we don't find ABG right and left. So they started, they did some modification to the existing Berlin classification. So This is called Kigali modification. The duration is the same with the Berlin ones, okay? So the radiologic finding also the same, but this time they added ultrasound. Since ultrasound, we can use the right and left in the critical setup and emergency, and even in the poor resource setup, so they can be used. So difference being between the, to differentiate whether it is cardiac or lung pathology, especially in the ultrasound. X-ray is straightforward, but in ultrasound, the finding of B lines and pleural lines, especially it is in the cardiac ones, they will have flat pleural line, but in the lung ones, they will have subpleural consolidation. It will be rough. So that was the addition thing. On top of that, they used the hypoxemia saturation to FiO2 ratio less than 315 less than or equal to, because you will not have ABG, so SpO2 to FiO2 ratio will be very important. So the other ones is they removed from the Berlin, they removed the PEEP requirement, because physiologically the patient or a person have 3 to 5 PEEP, so that one was added as consideration in the modification. So they used this definition. Coming to the epidemiology part, I tried to see general like global status, but commonly it's mentioned the Europeans and the Americans are mentioned. And into around 2000, there was 86 to 100,000 person a year, and it gradually decreased up to in 2008, that was documented as 38.9 per 100,000 person a year. And ARDS was attributed as ICU admission, 10% of ICU admission are due to ARDS. In Ethiopia, I tried to see some papers, but these ones are that's what I found. Okay, ARDS major predictor of ICU mortality, and overall ICU mortality being 39.7%, but it is one of the major predicting factor of ICU mortality. And in COVID and severe COVID patients, 32% of this population will develop ARDS, and these they have more risk if they are the patients are advantage age and male sex, especially in the COVID-19 ones. But in general population, females are, other than COVID, females are more major predictor factors. Okay, so coming to the pathophysiology, there are a lot of multiple things are involved in the pathophysiology of ARDS. So one is the endothelial injury, the vascular side, and the alveolar side. From the endothelial injury side, there will be leaky vessels, especially capillary vessels, capillaries, and this intravascular content will pass into the interstitial, and which will impair subsequent oxygenation and such. And also this leaking will be too much leaking of this fluid from the vessels, from the capillaries, will be too much for the lymphatic system to drain it up. So drain it all, so it will congest in the lung, and it will impair oxygenation. And the other ones, the alveolar side. The alveolar side, there are two cells involved in this pathophysiology. Okay, type 1 cells and type 1 pneumocytes and type 2 pneumocytes. And type 1 are more related to the closing the lines, the epithelial lines of the alveolus, and they are also associated with cleaning of these secretions and such fluids. So they are when they are damaged, this function of them will be impaired. So the interstitial fluid which is present will pass into the alveolar space. The other ones are the type 2 pneumocytes. They are one of course, as we know it, they produce surfactants, and they also differentiate into type 1 pneumocytes. And so if then this damage to these cells will impair the secretion of this or production of surfactant, and the patient will have a hyaline membrane, and this will decrease the surfactant ability of this fluid. So the alveolus will be collapsed. So they will do this. They will produce these hyaline membrane features. Okay, so the other remaining ones, the barotrauma related pathophysiology, especially this is called ventilator associated lung injury, especially when there is larger volume, greater than 10 ml per kg. Previously, they used to use larger tidal volume, so 10 ml up to some 12 ml or so. So these larger volumes, they induce inflammations and such, which is like typical of the ARDS feature. So the patient will end up having or worsening of the already existing lung problem or creating his own issues. So the other ones related to the peak pressure or increased pressure in the airway, that will give him, patient will develop this barotrauma. The other ones are complete collapsing and opening frequent, complete collapsing of this will also give the patient atelectotrauma. These are the three mechanisms involving the pathophysiology of ARDS. So the first studies, as you know it, the ARDS net trial, the studies, they started to differentiate the pathophysiology, physiology of this, the pathology of this ARDS, and they said they can be classified as type 1 and type 2. Type 1, once they are primary ARDS, it means that the pathology is due to from the lung pathology itself. It might be aspiration, it might be pneumonia or other issues, which is primarily in the lung. And type 2 are those who are systemic causes such as sepsis, pancreatitis, burn, and such. So this definition has its own important clinical importance, which we will come when we will talk about the fluid management. We will discuss this again. So these are the main pathophysiologic process happening during ARDS disease. So what will happen? Let's say after this all problems, so the oxygenation will be impaired. So impaired gas exchange will be will appear. So hypoxia is one of the consequences, and also, and at the end, especially at the end, the patient might develop having hypercapnia. So hypercapnia is not that common as when you compare with the hypoxia, but at the end, especially, one of the poor prognosis signs actually, because they have low tidal volume and such, so they are leading to manifest. The other consequence is decreased lung compliance, so ventilation will be impaired because of the lung is so thick and congested, so we cannot pump it and expand and oxygenate well. So that was that's one of the complications. The other ones is pulmonary hypertension. Okay, pulmonary hypertension also will happen. Actually, in around 50% of patients with ARDS, they will develop pulmonary hypertension, arterial hypertension due to vascular constriction, vasoconstriction. Okay, when you talk about the pathologic stage of ARDS, there are exudative, fibroproliferative, proliferative, and fibrotic phase. The exudative phase is the first phase. Okay, within 3 to 7 days, and there will be diffuse alveolar damage, as we discussed previously, highly membrane formation, the alveolar hemorrhage and such, and these are the first phases. Okay, then after this one, the fibroproliferative phase will happen, but there is no clear line between these two phases, and the process starts while the exudative phase is already in place. The process of fibroproliferative phase will start. Okay, so they usually do 7 days up to 21 days, and as we discussed previously, type 2 pneumocytes will start to generate the type 1 cells, surfactants, and such. So the edema will decrease gradually. At the end, there's a fibrotic stage of ARDS. All of the patients of ARDS, they will not go to the ARDS phase, the fibrotic phase. Okay, some of the patients will progress to this phase. Okay, all of them will not go to this phase. Commonly, after 2 to 3 weeks. Okay, then the patient will end up having alveolar and interstitial fibrosis. Coming to the clinical presentation. So clinical presentation, patient will have acute dyspnea, will present within 6 to 72 hours of insult, and also they will have manifestations of the primary underlying cause of this ARDS. If it's patients having pancreatitis, they will have manifestations of pancreatitis. If that's burn, you will see manifestations of those. So the underlying conditions will also manifest. On physical examination, the patient will have tachypnea, tachycardia. On a chest examination, you will see bilateral crackles and wheeze also sometimes, and hypoxia for sure. The patient will have these issues on top of the underlying cause of the ARDS, as we discussed in the history part of this slide. Coming to the etiology and risk factors of ARDS, from the overall causes, including primary and secondary ARDS, pneumonia is the commonest one. Say up to 40% of the time, pneumonia is the cause. And the next one, sepsis and aspiration. But if we talk about secondary causes, if you are talking only secondary cause, sepsis will be the commonest cause of or etiology of ARDS. Okay, these are ARDS have almost up to more than 60 causes. Okay, these are the commonest ones what we see in daily day-to-day clinical activity, but the list is long. Okay, as it's mentioned here, bacteremia, sepsis, trauma, fracture, okay, burn, massive transfusion, pneumonia, aspiration pneumonia, okay, drug overdose such as aspirin and opioids, near drowning or submersion injuries, post perfusion injury, especially after cardiac surgeries and such, pancreatitis and fat embolism. These are the causes of ARDS, but the list goes on. Okay, from the general risk, as I discussed previously, from the general risk, patient with advanced age, female gender, in COVID, it will be male gender, okay? An alcoholic person, and higher a patient who has a higher Apache 2 score. These are the general risks of ARDS. Okay. So if I am going fast, please let me know. Okay. Okay. So then what will be the complications of this? What are the complications of this ARDS? As we discussed previously, barotrauma is one of the complications, especially related to mechanical ventilator settings and the physician's experience managing this problem, and accidental extubation, especially breathing with this problem. The patient will be irritable, anxious, so they will be eager to extubate themselves, so they should be sedated well. And also right mainstem intubation, especially if the person is not experienced much in intubating this patient. Okay, and also they will develop delirium, ventilator-associated pneumonia, and UTI, especially the ventilator-associated pneumonia. These people, this kind of patients, they will stay on the mechanical ventilator for long duration. Okay, so they will not only have only once, they might have twice, 3 times ventilator-associated pneumonia. So these are the common complications of ARDS. And concerning AKI, acute tubular necrosis are the commonest ones. Okay, DVT and stress ulcers, since these patients will be on the bed for prolonged duration, so they will develop DVT. So she should be on DVT prophylaxis, and also ulcer. Also, they will develop in stress condition, prolonged mechanical ventilation issues. So they will have peptic ulcer, stress-induced ulcers, and also concerning giving, this patient they will usually use broad-spectrum antibiotics, and the side effects of this is one of the C. difficile colitis, and also they will develop drug-resistant bacterial infection, MRSA, VRL extended broad-spectrum beta-lactamase ones, and at the end, the patient after discharge, they will have functional impairment and PTSD also, and also weakness. They lose around 18% of their weight, initial weight. So this is a very critical condition. This is critical condition. So coming to the workups, we work up, we will do laboratory and imaging. Sorry for the spelling here. Laboratory and imaging. So to start with the laboratory ones, okay, ABG is commonly used ABG It's commonly used if your facility allows you to do that. Maybe one of the common investigation we do concerning ARDS patients. What we will find in the ABG, of course, hypoxia, the commonest ones. Then the next patient will initially develop respiratory alkalosis. And when the disease progresses, they will develop respiratory acidosis. And also if the patient causes sepsis, they might develop metabolic acidosis. So these are the things you will see in ABG, arterial blood gas analysis. Okay, BNP also is one of the investigations. So less than 100 is a cutoff point to rule out the cardiac issue and suggestive of ARDS. And if it is more than 500 picogram per liter per ml, it is suggestive of cardiac issue. With concomitant cardiac issue might also be there. And the CBC, leukocytosis, leukopenia, and other anemia, you can find all that. Renal function test, liver function test, as we discussed, renal tubular necrosis, and such that have the common one, so they will find renal derangement on the laboratory. So coming to the imaging, chest X-ray is commonly used to diagnose ARDS, and especially if the resource limited setups, that is your diagnosis. That's imaging, best imaging modality to start the workup of the patient. Okay, sorry. So what will happen is the patient will have like this typical consolidation. They will have peripheral consolidation. When it worsens, it will go into hilar area. Also, there's another X-ray here. So this one is also the same thing. So the patient is having, this one is having bilateral consolidation here, and this one also, as you see. As you see, patient is intubated. It looks like from portable X-ray. So the patient is intubated here, and he has a lot of lines going on. A lot of lines are there. So these are the typical findings concerning the ARDS, okay? But the imaging might be different depending on the fluid status of the patient. If the patient is congested, the patient will have, they will have more prominent opacification, and if the patient is dehydrated, after diuretics and such, the consolidation will decrease, opacities will decrease. The next investigation is CT scan of the chest. Okay, so CT scan will be ordered usually to diagnose complications. Okay, if you have already radiology X-ray findings, that's enough. But if you are suspecting complications associated with barotrauma or the disease progress itself, CT scan is your investigation. Okay, this is a typical finding. As you see here, the upper part is aerated, more aerated, and there is also the lower part almost white out. The middle a gray, a bit a gray one. You can see these three layers of lung pathology. Okay, the next investigation we use is echocardiography, especially if you are thinking cardiac dysfunction might be there. So that's your investigation. And point of care ultrasound or critical care ultrasound also, you can use that one to diagnose and follow patients in the with the COVID, with ARDS, okay? Bronchoscopy, if you are suspecting infections and you have another differentials, that's your investigation you can do also, bronchoscopy. Coming to the prognosis, ARDS patients, they have mortality of 40%. Previously, it used to be like in the 80s, okay, gradually with understanding of the pathophysiology and modern management techniques, gradually is decreasing. Now it is 40%. And most common, most diseases appear caused by the primary illness, as we discussed. The primary illness is the most common, and sepsis and multi-organ dysfunction are most common cause of death. And advanced age are one of the risk factors, okay? Coming to the depending on severity, so mild ARDS, the mortality around 34%, 34.9%, moderate ARDS 40.3%, and severe ARDS 46.1%. So the more the severe, the mortality is higher. Okay, coming to the treatment parts. Okay, coming to the treatment part, we have supportive care, oxygen therapy, mechanical ventilation, and investigational or ineffective therapies. At the end, we'll discuss pediatrics also. Supportive, coming to the supportive cares, sedation is one of them. So patient, as we discussed, the patient will be in pain, anxious, so they will be irritable, and they should be sedated well. So the target is with a RASS score of 0 to 1. The patient will be calm, sleeping, and that would be the perfect level of sedation. If the patient is deeply sedated and also agitated and such, those are the level of sedation which we don't want. Okay, because it's not only that patient being awake or deeply sedated, also the ventilation, synchronization of this breathing will be harmed or deranged. So that's why we are focusing on sedation. Okay, paralysis also. Patients who are having desynchronous breathing, those patients should be first, they should be sedated. Then on the sedation also, if they're still having that, they should be paralyzed. How to paralyze the patient? Patients, they used to use like infusion in intermittent bolus therapies, and the intermittent bolus are one that are better, and infusion ones the patient are treated with prolonged intubation and such. So they prefer. Recently, we prefer putting a patient on intermittent bolus paralysis medications. Okay, neuromuscular blockers. Okay, the other ones, hemodynamic monitoring. It is very crucial in the monitoring of this AR-based patients. The non-invasive ones and invasive ones. The non-invasive ones already, as you already know them. So we have non-invasive monitoring on top of that invasive monitoring. Okay, central venous catheter and pulmonary arterial catheter. They used to be compared in the previous studies, and mortality-wise, there's no significant difference between those two monitoring techniques, but complication is higher with pulmonary arterial catheterization. So you can just use the central venous catheter and follow the volume stats of patient and such. Okay. Coming to the nutritional support, so enteral feeding is a preferred one, and ideally it's better to start with low feeding volume, then gradually we will increase if the patient is tolerating the feeding. It has own nutritional importance. On top of that, the infection risk comparing with parenteral nutritions, the enteral nutritions are better ones. So we prefer starting feeding with enteral route. Okay, glucose control, ideally it's the same with other critical patient. Ideally it's supposed to be kept between 140 and 180 milligram per deciliter, and with this we should keep on this side. Okay, on this range. Also nosocomial infection treatment, as we discussed, I said previously, 50 to 55% of the patients they will develop nosocomial infections. So the mortality will not be affected, but these are the things to care. Other ones, the issue of DVT and GI ulcers. So patients should be on DVT prophylaxis and ulcer prophylaxis based on the your institution's protocol. Okay, so we usually start with enoxaparin 40 daily, or you can use unfractionated heparin depending on your resource. Okay, ulcer prophylaxis also should be started. Glucocorticoid medications, they are used especially when you fail to improve with the standard care, standard treatment. we can start glucocorticoid, but they should be started within 14 days of onset. Okay, if it is more than that, already fibrotic phase started and the patient will not improve, will not benefit, even they will end up having complications. The others also, if the patient is having, for example, like this non-ARDS indications means if the patient is having septic shock, let's say, you gave him fluid, you gave him your process, still patient is hypotensive, they have to be on glucocorticoids, okay? The other indication is severe COVID-19, which you already know. That one also we'll discuss in subsequent slides, okay? So coming to the oxygen therapy, the options in the oxygen therapy, they are divided into 4. One, using of higher effort. If you start with the lower, you start with the lower ones. If the patient is not tolerating that one or keep being hypoxic, you have to increase. The other option is decreasing oxygen consumption. How will decrease? We'll discuss later. And improve oxygen delivery techniques, manipulate the mechanical ventilation setups, okay, support. So these are the options. We'll discuss each of them in the subsequent slide. So increasing oxygen, as we discussed previously, oxygen support, as we discussed previously, the fluid status in the congested lung will affect the patient's oxygenation. So we'll focus on fluid management because it is very important. And from the fact study, we saw that conservative management, they are more better with maintaining oxygenation than the liberal ones, okay? Negative balance sides, they are also associated with benefit in survival, okay? So also type 1 ARDS, type 1 ARDS will more benefit from conservative approach than type 2. As we discussed, type 1 ARDS are those the ARDS cause is starting from the lung itself, such as pneumonia, aspiration, and such. So they will benefit more from the fluid management, from the conservative fluid management. If the patient is still having hypoxia and still having high venous return or increased higher venous return more than 4 millimeters of mercury, you can use diuretics, and also you can use dialysis to decrease this wet lung. So these are the preferred, this is the preferred fluid management, especially in the conservative ones, in the type 1 ARDS. But the patient, if the patient is having type 2 ARDS, which is due to systemic causes such as sepsis, this patient, initially they will benefit at early phase, they will benefit from liberal fluid administration, okay, because they are usually fluid bearing. So they will benefit from that approach. Going to the decreased oxygen consumption, now we are talking about the increased oxygen FiO2 therapy, but the next one will be decreased oxygen consumption. How do you decrease oxygen consumption in this patient? As we said previously, if the patient is agitated and fighting, the patient should be sedated. If a patient is in pain, especially they will be in pain because they are having a lot of tubes. ET tube itself is painful, central lines. Sleeping in one bed for prolonged duration is also painful. So such patients are very in pain, so they should have analgesia, and fever also should be managed, and also agitation. After sedation and such, still patient is having dysynchronia and such, paralysis also will help them, okay? Neuromuscular blockers also will be useful. The third approach is increasing oxygen delivery. Okay, if the patient is anemic, they should be transfused and with a target of hemoglobin 7. Okay, and also treating the underlying cause, and these are the issues. And coming to the investigational therapies, giving nitric oxide and prostacyclins, they are associated with increased oxygen saturation or increased partial pressure of arterial oxygen, but they don't have mortality benefit, but they will increase the oxygen saturation of the patient, okay? So they can be used, but the mortality wise, they are not that much, okay? The fourth approach is ventilator management, adjusting the ventilator setups. So we'll talk about ventilation management of AR-based patient, okay? So coming to the, first we'll start with non-invasive ones, okay? From the non-invasive options, non-invasive ventilation versus high-flow nasal cannula. A lot of literature are coming these days, and high-flow nasal cannula is well tolerated, and they are also having improved mortality benefit. Okay, and why are they well tolerated? Because the mouse, the patient, the high-flow nasal cannula will be put on the nose, and the patient will have will be comfortable in eating, drinking, and such. So the patient is much comfortable. If you are putting the patient on non-invasive positive pressure ventilation, the patient will be not much in comfort with that one. Okay. So the non-invasive ventilations, if the patient is having concomitant comorbidities, that's where you use non-invasive ventilations, such as CPAP and BiPAP. Okay. And if you fail with this one, the patient, we should go and use invasive mechanical ventilation. So to talk about the invasive mechanical ventilations, the initial settings, as you know, the lung protective ventilation, this is the best and proven treatment options of these AR-based patients. The tidal volume low, less than 6 ml per kg of the ideal body weight. This famous, the ARMA trial showed us there is 22% reduction in the mortality if you use 6 ml per kg of the ideal body weight. Okay, so if you use more than this, especially 10 and such, they will end up having volume trauma and biotrauma and such. So it's better to use a smaller tidal volume. This is the most important message from this whole presentation. This is the best message I have for you, that using low tidal volume is very important as life-saving option. Okay. How to estimate the ideal body weight? As you know, whether the person is fat or thin, the lung volume, the chest cavity stays the same. So using the measured body weight to say the tidal volume is very dangerous, so you have to use this formula or use ideal body weight. So for male, in centimeter unit, 50 plus 0.91, height minus 152.4, and for female, 45.1, 45.5 plus 0.91 times the height minus 152.4. This will be the ideal body weight, and you use that one to calculate the tidal volume. Okay. Coming to the modes, ACVC or volume control assist control is the preferred setting, especially at the beginning. Okay, we are talking about the initial settings, right? So at the beginning, volume control assist control is preferred ones. Okay, if we fail with volume control mode, we can also use the pressure control ones, but this is the initially commonly recommended ones. Okay, this also depends, the choice of mode also depends on the patient's or the doctor's experience. If they cannot troubleshoot these modes, they have to use the modes they know well to adjust accordingly. Okay, and the next things to set is target plateau. It should be target plateau pressure should be less than 30 ml, 30 centimeter of water. So how to use the next step will be setting the PEEP, right? So this is a WHO recommended FiO2 PEEP table. You can use this table to adjust your PEEP and FiO2, and accordingly you can escalate. You can start from the smaller ones, you can escalate accordingly. This is especially for resource limited setup. This is the perfect option. You can start with small PEEP and increase according to the patient's requirement. But in advanced setups and base setup, they use this esophageal pressure or transthoracic pressure. What they do is they will insert like a tube, like it is like NG tube. the tube will stay in the esophagus and will measure. And from the measurement from this monitor minus the PEEP, if it is between plus or minus 2 in the plus or minus 2 range, then we are happy with that. If it is not so, we have to adjust our PEEP to get this plus or minus 2 centimeter of water range. So this is the best, this is the better option, but in our setup, we don't usually have this one. So we use WHO FiO2 PEEP table to target our PEEP and FiO2. Coming to the oxygenation goal, partial pressure of oxygen between 55 up to 80 or saturation 88 up to 95, we are happy with this range. So what are the side effects of this lung protective ventilations? It has done, especially we are using low tidal volume, so the patient will have hypercapnia. So the patient will develop permissive hypercapnia, and patient will have also might develop auto PEEP, and they might need sedation because they need more tidal volume to ventilate, or desynchrony, so they should be sedated. Sedation is one of the issue. And also double triggering. Double triggering means, let's say patient is requiring 500 ml, and you are setting the patient's breath around 300. So they will trigger more. They will trigger more whenever they get set tidal volume. They will trigger more, and they will end up with double triggering. This is not a good thing. So we have to manage according to this waveforms. They show that these ones, as you see, there's also double triggering here, here, and here. This is a volume controlled ventilation. And the pressure controlled ventilation also, you will see it here, okay, and these ones, okay, you see these ones, okay, these ones typical, okay, and also these ones. So they are having double triggering. How do you manage double triggering? We'll talk, okay. So after setting this, the initial settings, what are you going to do? We have to follow the patient's monitor, the vital signs and such. So on the monitor and the mechanical ventilator display, the plateau pressure is one of the things to follow. The goal of plateau pressure is less than or equal to 30 centimeters of water. If the plateau pressure is higher than this, okay, you have to adjust the tidal volume by 1 ml per kg to decrease to the acceptable range of plateau pressure. And the patient will have increased carbon dioxide, so you have to adjust also, you have to increase also the respiratory rate to ventilate the patient well. So whenever you decrease the tidal volume by 1 ml per kg, you have to increase the respiratory rate also. So if the patient is also double triggering and the plateau pressure is less, so less than 25 centimeters of water, and tidal volume is less than 6 ml per kg of body weight, ideal or predicted body weight, the tidal volume can be increased. So to get the target to get the plateau pressure target between 25 and 30. With this rate, with this target rate, we are happy, and the patient will be fine. If still the patient is double triggering, despite being adjusted, the other one, the patient can be sedated, and also giving anti-pain, and at the end using neuromuscular blockers to paralyze the patient and have good ventilation. And the next is gas exchange. We will follow ABG, and accordingly you will adjust the FiO2, PEEP and such, okay, and the respiratory rate. The other thing to follow is driving pressure. Driving pressure is very important thing, especially talking about prognosis, subsequent improvement and such. So the driving pressure, ideally it's less than 15. We are happy with less than 15, but it's more, the patient will have poorer outcome. So that's why we are focusing on driving pressure. How to calculate it? Plateau pressure minus PEEP. This is driving pressure. Now this is more of static driving pressure, okay? And let's say with these all issues, the patient is still not oxygenating well. So what are the subsequent options? If the patient is not oxygenating well and the plasma pressure is going up, so we have some techniques. Prone position is the commonest ones, recruitment technique, pharmacological, and ECMO. I make the sign here, this tick sign, to tell you that the mortality benefit from these two options is very good, but this one, the recruitment technique and pharmacologicals, they don't have mortality benefit, but they are good in oxygenating, increasing your oxygen level. Okay, coming to the first one, prone positioning. So there is famous PROSEVA trial with the did study comparing those who are on prone and those who are on supine position, and the mortality rate different is very significant. As you see, there's 16% mortality in this arm, and supine arm 32.8%, and the odds ratio, as you see, it's very good, 0.42. So this is the outcome of PROSEVA trial, and since then we are using prone positioning as one of the refractory cases. The other ones, the recruitment techniques increasing PEEP, as we discussed previously, the WHO FiO2 PEEP graph, and their study done alveoli trial shows, it is old trial actually, it shows some mortality benefit, but statistically still not significant, but clinically there is some decreasement in around 3% from those who are using low PEEP and high PEEP. Those who are using high PEEP, they have decreasement in mortality, but that was not statistically significant. There's another study which is done by Brian and his colleague. High PEEP is associated, which suggests that high PEEP is associated with more mortality benefit, especially in those who have moderate and severe ARDS. As I told you, transthoracic pressure monitoring or transesophageal pressure monitoring is useful to set the appropriate PEEP and driving pressure, talking about prognosis. And if the high PEEP is, after setting the patient into high PEEP, if the patient is not tolerating, is not responding, or oxygenation is not improving, it's supposed to put them back down to the lower PEEP range, because the higher PEEP, they are associated with their own complications, like cardiovascular complications and barotrauma, and so they have to be put down to the normal range. If they are improving, we can keep them on the higher, in the PEEP responsive patients, we can keep them in the higher PEEP range. Okay, the other ones which is done recently this year, the high PEEP with without or with minimum recruitment techniques associated with higher mortality survival benefit than with high PEEP with recruitment techniques and with a low PEEP one. Especially high PEEP with recruitment, they are deleterious. Even the mortality is higher than with those with low PEEP one. So it is dangerous to use high PEEP on top of a recruitment technique. Okay, so these are the four things concerning PEEP, making PEEP more favorable. Okay, so that's why I take these all 4 slides. The other technique, the other recruitment maneuver, or the recruitment technique, is open lung ventilation. This open lung ventilation talks about, I want you to concentrate on this, the lower part of the slide. There are 2 areas where the direction of the slide, the line changes, this one. Okay, this is called lower inflection point, and this is called upper inflection point. You can see the reflection of this on this one. Okay, on the loop of the mechanical loop curve waveforms. Okay, on the mechanical ventilator, you see this pressure volume curve. This is pressure volume curve, and this is the lower inflection point of that. And you will set the PEEP just 2 centimeters of water above this. Okay, you will put 2 centimeters of water above this. But the problem is that there is no mortality benefit, but it's one of the options, especially in pediatric ones. They are used commonly. The 4th recruitment maneuvers you can use a PEEP of 30 to 40 centimeters of water for duration of 40 seconds. Okay, then after that you will decrease the PEEP to the previous mode, and you should not do this more than once. Why? As we discussed previously, high PEEP is very dangerous thing, so associated with its own cardiovascular complications and lung issues. So they should not be done more than once. And this is one of the ways to recruit the lungs, atelectatic lungs. Okay. The other option is using pharmacological, as we discussed, neuromuscular blocking, pulmonary vasodilators, nitric oxide and prostacyclin, and corticosteroids. These are not associated with significant mortality benefit in general ones. Okay, these two there's no significant mortality benefit, but corticosteroids, especially in COVID-19 ARDS, they are important. Okay, and ECMO, especially RD, using ECMO within 7 days of the insult or 7 days from the onset of disease, they are more beneficial, and also they have mortality benefit. So ECMO will be the last modality, especially if you don't have ECMO in your facility, and if you can access that one in the near facility, it's better to send the patient to that facility. But I don't think we have it here in Ethiopia, this ECMO machine, but we can learn from you if there is if it's available in Addis. So coming to the COVID-19 ARDS treatments. So as you know the pathophysiology, so we'll go directly to the management part of this COVID-19 pneumonia. Okay, COVID-19 pneumonia ARDS. Okay, so the treatment will be supportive care using ICU protocol. The supportive care is same with the other ARDS cause. Okay, and the additional thing what we use is infection prevention and control techniques, especially during the intubation and ventilation part. They should strictly adhere to the IPC protocol of the institution you are working. The next option, non-invasive ventilation, invasive ventilation, and specific treatment. So non-invasive ventilations, comparing high flow nasal cannula with non-invasive ventilation, high flow nasal cannula will decrease the rate of intubation, but mortality-wise, the studies doesn't suggest more, but they have reduction in intubation rate, so that's good thing. But when do you use non-invasive ventilations? Okay, especially if the patients having COPD, asthma, cardiogenic pulmonary edema, or obstructive sleep apnea, the patient will benefit from the non-invasive ventilation. Otherwise, the high flow nasal cannula is better than non-invasive ventilation. So when do you decide to intubate this patient? Okay, the patient will be, as you putting them non-invasive ones or high flow nasal cannula, and the patient is gradually, rapidly deteriorating, or increased work of breathing, decreased consciousness, very agitated and such. And also, if the patient is having hemodynamical instability, you right away should consider for intubation. How to intubate? You should adhere to the IPC precautions of the facility and use HEPA filter and two technique, 2%. So before going in and intubating the patient, you have to sit down with the family and discuss the issues, because as you know, mortality-wise, mortality intubated patient, up to some literature saying up to 88% and so on. So the wish of the family should be respected. And if the family decided to not to be intubated, then you will adhere to that one and will continue with end of life care. But if the family decided to go ahead and to intubate the patient, then you will go ahead and intubate the patient. So you have to sit down with the family and respect their wishes. So this is one of the things you should consider, especially working in the ICU. So invasive ventilation, the same thing, With the other ARDS causes, lung protective ventilation is still the very important ones. Low tidal volume, 6 ml per kg, then you will adjust accordingly. If still not oxygenation is not good, still with a low tidal volume ventilation, then prone positioning can be done. And trial of recruitment in high PEEP you can use, and then neuromuscular blocking agent, pulmonary vasoconstrictors, they can also be used, but mortality wise they are not this much. So ECMO also is recommended, especially in early phase, as discussed previously. Within 7 days of the insult, you should consider doing ECMO. Specific treatment, these are more specific to COVID-19. ARDS, dexamethasone, 6 milligram IV daily. You can also add it on tocilizumab with 80 milligram per kg IV once, and the other ones also mentioned. Okay, these are the specific treatment for COVID-19 ARDS. Last but not the least, pediatric ARDS, and I'm going fast. Sorry. So the last part is pediatric ARDS. So the pathophysiology, it has its own issues, but there are some common things. Coming to the definitions of ARDS, with PARDS definition, ARDS symptoms or sign within 1 week, and new change not explained by cardiac dysfunction or fluid overload, and radiologic finding, especially in the X-ray and such, bilateral infiltrates, new bilateral infiltrates with parenchymal disease. Especially what's the difference from the adult one is sometimes the unilateral opacities can also be considered ARDS definition. Okay, can be considered in the ARDS definition. And also definition of hypoxia is different in pediatrics when you compare with these other adult ones. So they used this after the pediatrics acute lung injury consensus conference. They used these classifications: mild, moderate, and severe ones. And in our setup, oxygen saturation index, this is oxygen index, oxygenation index, oxygen saturation index. Milder ones for oxygen index between 4 and 8, moderate 8 to 16, more than 16. Severe ones, oxygen saturation index 5 to 7.5, mild 7.5 to 12.3, moderate more than or equal to 12.3. It is considered as severe ones. The formula is written here. The formula down in here is mean airway pressure. Mean airway pressure times FiO2 over partial pressure of oxygen. You can find the oxygenation index. So if you are calculating for oxygen saturation index, you can use mean airway pressure, which is mean airway pressure will be displayed on the mechanical ventilator. So don't worry about this. The FiO2 you already know, divided by the saturation, oxygen saturation. This will give you oxygen saturation index, and it will help you define the severity of the ARDS. So the treatment options, especially in pediatrics ARDS, these recommendations are taken from the Pediatrics Acute Lung Injury Consensus Conference, which is published in 2015. Most of the recommendations, these recommendations are very weak recommendations, and some of them are weak recommendations. So the tidal volume will be, the recommendation is 5 to 8 ml per kg. As a famous Nielsen textbook recommends 6 ml per kg, and the plateau pressure range is less than 29 up to 32. Why is it this one high? Because as you know, pediatric airway is very low, very narrow, so they will have a higher plateau. So that's why the plateau cutoff point is higher. On the severe ARDS, you can use the 10 to 15 centimeter of water PEEP as initial setup, and you can increase gradually the PEEP. Okay, prone positioning also have effect in pediatrics ventilation of ARDS patients, and high frequency oscillatory ventilations is alternative for standard care, but they are not the first ones, like the desperate measure ones. So these are the topics which I presented for, which I prepared for today, and these are my reference. And also I forgot to write Nelson here. And thank you. If you are, then the next question, the next part will be looking at your Q&A.
Yeah, thank you so much, Doctor. It was an amazing slides. So participants who have questions, please write on the Q&A section. So please do not write on the chat box. Write your questions on the Q&A only, and Doctor will address those. Go ahead, Doc.
Okay. So there is question raised by two participants. Their concern is Apache score. This will Apache score. We use it in the critical setup where to talk about the level of severity of the patient. And there are a lot of Apache scoring system 1 to 4. Then the Apache 2 ones are the better ones. It will tell us the severity. You can use some calculators to determine what kind of what is the score of your Apache 2 score of your patient. Okay. So the next one, what is ECMO? Extracorporeal membrane oxygenation. It is used to oxygenate the patients to increase patient's oxygen you take. Commonly, ECMO, we use the better ones is VV ECMO, veno-venous ECMO. You take the patient's blood, you oxygenate and give it back. There is another thing called again extracorporeal carbon dioxide or ventilation. Those are, this one is doesn't have mortality benefit or clinical importance. So it's not recommended to use. So ECMO is the better one, and you take the patient's blood, you oxygenate and you give him back to the patient. So pediatric ARDS, yeah. So concerning the pediatric ARDS, the Pediatrics Acute Lung Injury Consensus Conference, on the definition of the ARDS, they said all population, all pediatrics, including the neonatal, they are involved in the diagnosis. But the patient can have a congenital heart defect and have ARDS. The thing you should focus on is a lung pathology, or the lung problem the patient is having now is due to congenital heart failure or the ARDS. So that one you should keep an eye on. But if the patient can have congenital heart defect and have ARDS at the same time, if I think this is the question he's trying to ask, I think. So yeah, the diagnosis, recommended diagnosis of ARDS for special population. The X-ray is one of the things mentioned in the pulse or pediatric acute lung injury consensus conference once. It says remdesivir. Yeah. So I tried to see some expert opinion concerning remdesivir, and remdesivir is not the first line medication, one of the first line medications, especially the first line medication which we are using in the COVID-19 ones are dexamethasone and tocilizumab. These are the first line medications, and remdesivir will end up in secondary or second line medications, yes. But still, experts recommend giving remdesivir in COVID-19 ARDS. to be the says so this one says outcome of mechanical ventilator. To be honest, I tried to see some patients, some literatures, but I couldn't find one. But yeah, this is a very important question. So the factorial says clarify about the factorial. If there are no other questions, I can focus on this. They try to check the fluid, whether liberal or conservative management in ARDS patients, and they found out that conservative management are better than liberal fluid management, and they also used this monitoring techniques using central line, central catheter, venous catheter, and peripheral pulmonary arterial catheter ones, and they try to see the difference of these ones between the, and there's no significant much benefit, but the complications is higher. Complications are higher with the pulmonary arterial catheter ones. So I think Dr. Avera asked one question. What is a frequent thank you. It says frequently challenge you faced in the management of such patient. How do you deal with this? So the frequently challenged one, having to fail to oxygenate well. That is the most frequently challenged ones. And you should have experience, especially in your facility, you should have the experience to use the next mortality benefit ones, mortality evidence proven options to improve your patient's mortality. And your facility should be or should be equipped with the staff to do prone position and follow them, and that will solve a lot of things. It will give you big relief while doing that. Okay. And one other last question. So how can we proceed for intubation if patient has a card which shows against intubation and family agrees on it? So this is a good question actually. Sometimes the family, the will of the family should be respected, especially in critical care. The family should be communicated concerning on major decisions what you do, especially COVID ones and other also. So you will inform the benefits and the problems associated with the intervention you are planning. If the family is refusing, then of the subsequent intubation, and the patient also having card with it, with his pocket, then you respect his will. So what you do is all the other medication managements other than the intubations. Okay, so especially in COVID ones, you will discuss, it says like end of life care. Some patients dying subsequently due to respiratory failure is high, so end of life care should be done. I think these are the questions.
Yes. Thank
you
so
much. A lot of questions,
much.
but these are the things. That's one of the small questions. Yeah.
Since we have a specific amount of time, we cannot address all of them. We apologize, guys. So thank you so much, Doctor, for this amazing presentation. Also the Q&A session. Thank you for sacrificing your time at this, I think it's an evening. So for sacrificing your time. We hope to see you on another setup or maybe in another training really soon. Yeah, thank you so much, Doc.
Thank you for having me. Thank you.